Welcome back to the deep dive. Today, we are opening up the hood on the human body's most critical engine. And I'll be honest with you. When I first looked at the source material for today, I felt my own blood pressure spike just a little bit. We are tackling ischemic heart disease, or IHD.
It's a heavy hitter. It's one of those terms that, carries a lot of weight in the medical world and, frankly, a lot of fear for patients.
Exactly. It sounds incredibly technical, doesn't it? Like something you need a PhD to even begin to discuss.
Yep.
But as we started digging into Chapter 11, which is our primary source today, covering everything from pathophysiology to the drug cabinet, I realized something surprising. At its core, this isn't magic. It isn't even really biology in the messy sense. It's engineering.
That's a great way to put it. It's strictly mechanics, a physics problem.
It's a supply and demand problem.
Yeah.
And that's the mission for today's deep dive. We want to strip away the scary Latin terminology and understand the economics of the heart. We're going to look at how this pump feeds itself, what physically happens when the pipes get clogged, and then this is the part I found really fascinating, the precise chemical tools we use to fix it.
And we're going to go deep on those tools because the pharmacology here is, it's really elegant. It's not just take this pill to feel better. It's take this molecule to change the physics of how your heart wall stretches. It's incredible.
I love that. So let's start at ground zero, the core definition. When a doctor writes ischemic heart disease on a chart, what is physically happening inside that person's chest?
Fundamentally, IHD is a starvation event. It means the myocardium, which is the fancy word for the heart muscle itself, isn't getting enough oxygen to do its job.
Simple as that.
The supply of oxygen has dropped below the demand.
The root cause is usually plumbing, right? The pipes?
Usually, yes. It's almost always coronary artery narrowing or obstruction. Atherosclerosis, the pipes are getting rusty and clogged with plaque, so the blood flow restricts. But the source material makes a really critical point right up front. IHD isn't a binary switch. It's not like you're either healthy or having a heart attack.
It's a spectrum.
It is a spectrum, absolutely.
Right, the text lays this out as a progression. It starts with something called silent ischemia, which that just sounds like the title of a thriller movie.
And it's just as scary. You have the lack of blood flow, the muscle is struggling, but the patient feels absolutely nothing.
Nothing at all.
We'll talk about why that happens later, but it's a huge blind spot.
Then it moves to chronic stable angina, which is that predictable pain when you exert yourself, every time I walk up the hill. And finally, you reach the edge of the cliff. Acute coronary syndrome and myocardial infarction, the heart attack.
That's where the tissue actually starts to die. But to understand how a person slides from silent to catastrophic, we have to go back to that economics analogy you mentioned.
The balance sheet.
The balance of supply and demand.
Let's unpack the demand side first. The heart is an engine. It burns fuel. The text uses the term MVO2, myocardial oxygen demand. What actually determines how much gas the tank needs?
Okay, so there are three main drivers. If you understand these, you understand everything about how we treat this disease. The first is obvious. Heart rate.
The RPMs.
Exactly. The faster the engine spins, the more oxygen it burns. It's a simple linear relationship.
Makes sense.
The second is contractility.
That's the force of the squeeze, how hard it's pushing.
Yes. Is the heart tapping the gas pedal or is it flooring it? The harder it squeezes to eject blood, the more energy it consumes.
Okay.
But the third one is the one that people often forget, and it's arguably the most important for understanding the drugs we use. It's intramyocardial wall tension.
Wall tension.
Yeah.
That sounds like structural engineering.
It is. I mean, think of the heart like a balloon. If you blow up a balloon, the rubber skin gets tight, right?
Right.
That tension in the rubber requires energy to maintain. In the heart, wall tension is determined by two things: the pressure inside the chamber and the size of the chamber.
High blood pressure.
If you have high blood pressure, the heart has to push against that resistance, creating immense tension in the walls just to open the valve.
So high blood pressure literally makes the heart work harder just to sit there and hold the blood before it even pushes.
Precisely. And a bigger heart, a dilated heart, like in some forms of heart failure, has higher wall tension too. It's simple physics, known as Laplace's law. Higher tension means higher oxygen demand.
The heart rate, how hard it squeezes, and this wall tension.
Those are the big three.
There was a really cool metric in the notes called the double product. I feel like this is something everyone should know because it's so easy to calculate.
It's a fantastic back-of-the-napkin tool for doctors. You don't need invasive monitors to guess how hard the heart is working.
Right.
You just take the heart rate and multiply it by the systolic blood pressure. That's the top number on the cuff.
HR times SPP.
That gives you the double product. It is a direct proxy for myocardial oxygen consumption. So if you're running on a treadmill, your heart rate goes up, your blood pressure goes up.
Your double product skyrockets.
It skyrockets. And if your pipes are clogged, that's the moment you get into trouble.
So the double product tells you the cost of the activity.
Exactly. If the cost is higher than your wallet, your oxygen supply can pay, you get ischemia.
Okay, so that's the demand side. The heart is a hungry, expensive machine. Now let's flip the coin to the supply side. The plumbing. This is where the deep dive got really interesting for me because I always assumed a blood vessel was just a tube. A pipe is a pipe, right?
Far from it. The coronary circulation is incredibly sophisticated. It's a smart system.
The text distinguishes between two types of vessels, R1 and R2. This seems like a crucial detail that most people miss.
It is the key to understanding why you can have a 70% blockage and feel fine until you don't.
Okay, let's break down R1. What are those?
R1 vessels are the epicardial vessels. These are the big arteries that sit on the outside surface of the heart. Think of them as the interstate highways bringing supplies into the city.
Okay, the interstate. Big, wide open.
Exactly. Under normal conditions, these R1 vessels offer almost no resistance. They are just conduits to get the blood to the destination.
And the destination is the R2 vessels.
Right. The R2 vessels are the intramyocardial arteries and arterioles. They dive deep into the meat of the muscle. They are the city streets and the driveways.
Got it.
And here's the secret. Normally, the resistance, the traffic control, happens here in the R2 vessels. They have smooth muscle that can squeeze or relax to control exactly where the blood goes.
So the city streets control the flow, not the highway.
Exactly. Now, imagine you get atherosclerosis. You get a blockage on the R1 highway, a lane closure.
So supply should drop, right?
Well, initially, no, because of a mechanism called autoregulation. When the R2 vessels, the city streets, sense that the pressure from the highway is dropping, they dilate. They open up the floodgates.
So they're compensating. They reduce their own resistance to make up for the blockage upstream.
Brilliant, isn't it? It's a self-correcting system. It maintains the flow. You might have a 50, even 60% blockage in your main artery, but your resting blood flow is perfectly normal because your R2 vessels are working overtime to keep the valves open.
That is amazing. It's a built-in backup generator. But I assume there's a limit.
There is a tipping point, and the text is very specific about this. When the blockage in the R1 vessel exceeds about 70%, the R2 vessels are fully dilated. They are wide open. They can't stretch any further.
The back's out.
They have used up what we call their coronary flow reserve. So now you're walking up a flight of stairs, your heart rate goes up, your demand goes up.
Right.
But your supply, it's capped. The R2 vessels can't open any wider to give you more.
And that is the moment of ischemia. The supply can't meet the new demand.
That's the cliff edge. And what happens next is a cascade of failure. And the first thing isn't pain, actually.
It's not.
No, the first thing is mechanical. The heart muscle stiffens. It starts relaxing properly between beats. Then it stops squeezing properly. You lose contractility.
So the pump starts to fail before you even clutch your chest.
Exactly. And that's often what people feel first, that sudden shortness of breath. The pump is failing. If the blockage persists, you can go into heart failure. Or if it's a total block, the tissue dies.
Which brings us to section 2. What does this actually feel like? Because we have this Hollywood image, right? The guy grabs his left arm, grimaces, falls to the floor. Dramatic music.
Right.
But the clinical presentation in the text is much more subtle.
It is rarely pain in the sharp stabbing sense. In fact, patients often correct you if you use the word pain. They say, no, doc, it's not pain, it's a pressure, it's a squeezing.
An elephant is sitting on my chest.
That's the classic description. Or burning or tightness, and it's visceral, it's deep. If a patient can point to a spot on their chest with one finger and says, it hurts right here, it's almost never the heart.
Why is that?
The heart doesn't have that kind of pinpoint nerve mapping. The sensation is diffuse, poorly localized.
And it travels. The radiation patterns are wild.
The left jaw, the shoulder, down the inner aspect of the left arm. This happens because the sensory nerves from the heart enter the spinal cord at the same level as the nerves from the arm.
So the brain gets confused.
The brain gets its wires crossed. It thinks the arm is hurting when the heart is the one sending the distress signal.
That's terrifyingly fascinating. And the text lists the specific triggers, which map perfectly back to our supply and demand model. Exercise is the obvious one, but cold environments.
Cold causes vasoconstriction all over the body. It clamps down your blood vessels to conserve heat.
Okay.
That raises your systemic blood pressure. And remember wall tension. If blood pressure goes up, the heart has to work harder to push against it. Demand spikes.
Walking after a heavy meal, I think we've all felt sluggish after a big meal, but for an IHD patient, it's actually dangerous.
Digestion is metabolically expensive. The body shunts a huge amount of blood to the gut to process food. We call it splanchnic blood flow. That's blood that isn't available for the coronary circulation. It's a resource war.
And the heart loses.
If the supply is already tight, yes.
And then emotional upset, anger, fright.
The adrenaline dump. It spikes heart rate and contractility instantly. Your double product goes through the roof in a split second.
And the text specifically mentions coitus.
Yes. It's physical exertion combined with sympathetic nervous system excitement. It's the perfect storm for oxygen demand.
Now, before we move on to diagnosis, we have to talk about the variants. Because not every heart problem looks like this clogged pipe model. There's something called Prinzmetal angina.
Also known as variant angina. This is the wild card. In classic angina, the pipe is clogged with plaque. It's a fixed obstruction.
Right.
In Prinzmetal, the pipe is spasming.
So it's clamping shut on its own, even if there's no plaque.
Yes, or very little. It's a dynamic obstruction. The smooth muscle in the artery wall suddenly contracts and chokes off the flow.
Wow.
And because it's a spasm, it doesn't follow the rules. It happens at rest. It often happens in the early morning hours, waking people from sleep.
And the ECG looks totally different, which is a huge trap for rookie doctors.
It is. Normally, ischemia shows up as ST segment depression. The line on the monitor sags. But in Prinzmetal, you get ST segment elevation.
And ST elevation is the code red for a heart attack.
In any other context, ST elevation means massive heart attack, rush to the cath lab. But here, it just means massive spasm.
Why does that distinction matter so much?
Because if you treat Prinzmetal like regular angina and give the wrong drugs, specifically beta blockers, which we'll get to, you can actually kill the patient.
You can make it worse.
You can make the spasm worse. It's a critical distinction.
Okay, so that's the spasm. Then there's unstable angina. This feels like the warning siren.
Unstable angina is the danger zone. It's when the pattern changes. If you've had chest pain for years, that only happens when you run a mile and suddenly you get pain while brushing your teeth.
That's unstable. The threshold has dropped.
Drastically. Or if the pain lasts longer than 20 minutes or happens at rest, this usually means a plaque has ruptured and a clot is forming. You are inches away from a full-blown heart attack.
And finally, the one that haunts me. Silent ischemia. The silent killer.
This challenges our entire philosophy of listening to your body. You have severe ischemia. The muscle is starving. But the patient reports 0 symptoms. No pain. No pressure.
How is that even possible?
We think it's related to a defective warning system. Maybe they have a naturally high pain threshold. But more often, it's seen in patients with diabetes.
Oh, of course.
Diabetes can cause neuropathy nerve damage that dulls the visceral sensation. The nerves that should be screaming in pain are damaged and quiet.
So their heart is sending out an SOS, but the phone line to the brain is cut.
Exactly. The text notes that nearly half of patients with diagnosed angina also have episodes of silent ischemia. They wear a monitor for 24 hours, and we see the heart struggling on the data, but the patient writes in their diary, "Watched TV, felt fine."
That's chilling, which makes the detective work of diagnosis so difficult. If you can't rely on the patient saying, ouch, what are you looking for?
You have to look for the subtle clues. The history is often unreliable because indigestion and anxiety can feel just like heart pain. So you look at the risk factors: smoking, hypertension, family history. But the physical exam, that's where the art comes in.
The expert highlights some very specific sounds, S3 and S4.
These are extra heart sounds. A normal heart goes lub-dub, that's S1 and S2. An ischemic heart is stiff. It doesn't fill smoothly with blood.
Okay.
The blood hitting that stiff, non-compliant wall creates turbulence, a third or fourth sound. So you hear lub-dub-dub or ta-lub-dub.
Oh.
A gallop rhythm.
Like a horse.
Like a horse, it's a sign of a struggling ventricle.
And then there's this systolic bulge. That sounds like a special effect from the movie Alien.
It's a palpable sign. It's really something. The doctor puts their hand on the patient's chest. When the heart beats, the healthy muscle squeezes inward. But the ischemic muscle is dead weight. It's weak. So the pressure from inside the chamber blows it outward. You can actually feel a paradoxical bulge on the chest wall with every beat.
Wow. That is visceral. Okay, so you have the physical clues. Then you have the labs. We have to talk about troponin.
The gold standard. Troponin is a protein that lives inside the heart muscle cells. It's part of the machinery that makes the muscle contract. It has absolutely no business being in your bloodstream.
So if it's in the blood.
It means the cell has ruptured. It means heart muscle has died. If you have chest pain and elevated troponin, that is a myocardial infarction. Game over.
But, and here's the nuance, in stable angina, the cells aren't dead yet. They are just hungry. So troponin is normal.
Right, and that's why a normal blood test doesn't mean you're safe. You can have severe disease with normal labs, and that's why we have to do stress testing.
Exercise tolerance testing.
Put them on a treadmill, hook up the ECG, make them run. We have to force the double product up. We have to provoke the beast to see if it's there.
It's a stress test for the supply chain.
Precisely.
Okay, so we've diagnosed it. We know the plumbing is faulty. We know the demand is too high. Now let's fix it. Section 4 talks about the goals of treatment.
There are two distinct goals, and they're not always the same. 1, quality of life. Stop the pain so the patient can walk to the mailbox.
Make them feel better today.
Exactly. 2, quantity of life. Prevent the heart attack and death.
Make them live longer.
And sometimes the drugs that do one don't do the other.
And before we get to the drugs, the text is very stern about the non-drug approach. We have to modify the risk factors.
We divide them into alterable and unalterable. You can't change your age, you can't change your gender or your genetics. If your dad had a heart attack at 40, you're on the back foot.
But the alterable ones.
Smoking, obesity, sedentary lifestyle, stress. It sounds like the same old advice your doctor gives you every year, but in this context, it's physics.
How so?
If you stop smoking, you stop the vasoconstriction and damage to the artery lining. If you lose weight, you lower the blood pressure, you lower the wall tension. It's direct mechanical intervention.
But let's be honest, we love the deep dive into the pharmacology, the pharmacologic arsenal. This section was my favorite because the mechanisms are so clever. We have 4 main classes of drugs.
And each one targets a specific variable in that MVO2 equation we talked about.
Let's start with class 1. The beta blockers. I call them the governor.
That is the perfect analogy. Beta blockers are the first-line therapy for chronic stable angina. They work by blocking the beta-adrenergic receptors on the heart. Essentially, they block the effects of adrenaline.
So they force the heart to chill out.
They put a governor on the engine.
Yeah.
They reduce the heart rate, that's negative chronotropy, and they reduce the force of the squeeze, that's negative inotropy. They lower the demand.
They don't touch the supply. They don't open the pipes.
Not really, no. They are purely about demand reduction. But there is a secondary benefit that is brilliant. The text mentions the target heart rate is 50 to 60 beats per minute. That seems incredibly low to most people.
Yeah, isn't 60 the bottom of normal? My fitness watch would panic.
It would, but we want it low for a reason. The heart is unique among organs because it only receives its own blood flow during diastole, the relaxation phase.
Wait, say that again?
When the heart is squeezing, in systole, the muscle clamps down on its own blood vessels. No blood gets in.
So the heart only eats when it's resting.
Exactly. It has to take bites of oxygen in between beats. So if you slow the heart rate down from, say, 80 to 60, you are spending much more time in diastole.
You're increasing the time the heart has to feed itself.
So beta blockers reduce the work and increase the lunch break.
Perfectly said. That's why they are the only drug in this class proven to improve survival after a certain type of heart attack.
That's right. However, remember Prince metal angina? The spasms?
Yes, the wild card. You said they were bad for that.
Beta blockers are a big no for Prince metal.
Why?
Because the blood vessels have receptors too. Alpha receptors cause constriction. Beta receptors cause relaxation. If you flood the system with a beta blocker, you block the relaxation signal.
And you leave the constrict signal all by itself.
You leave the alpha receptors unopposed. So adrenaline comes along and it can only constrict. You can turn mild spasm into a catastrophic knot. You have to know what you're treating.
Okay, that is critical. Moving on to class 2, nitrates, the vasodilators. Nitro, this is the one we see in movies. Pop a pill under the tongue.
It's the classic rescue drug. It works in, 1 to 3 minutes. Now, ask the average person how it works and they'll say it opens the coronary arteries.
And it does, right?
It does, a little bit. But that's not actually how it saves the day. That's a secondary effect.
It's not. What's the main effect then?
Its primary effect is on the veins and the rest of the body. Your legs, your arms, your gut. Nitrates cause massive venodilation.
So it makes the veins in my legs bigger.
Huge. And because veins are capacitance vessels, they're storage tanks. Blood pools in the periphery. It stays in your legs.
Okay, so if the blood is hanging out in my legs,
It's not returning to the heart. We call this reducing preload. If less blood comes back to the pump, the heart chamber doesn't fill as much. It doesn't stretch as much.
the wall tension drops.
And boom, oxygen demand plummets. It unloads the heart. That is the magic of nitrates. It's about reducing preload.
But there is a massive aha moment in the text about nitrates, tolerance. The body gets used to them incredibly fast.
It's a chemical limitation. It's a huge clinical problem. To work, nitrates need to be converted into nitric oxide by enzymes in the vessel wall. These enzymes contain sulfhydryl groups.
Oh,
If you take nitrates 204/7, you deplete those enzymes, you run out of the raw materials to make the drug work.
so if I wear a nitroglycerin patch for 24 hours straight,
By hour 24, it's just an expensive sticker. It's doing nothing.
so the solution is the nitrate-free interval.
You have to take the patch off. You need 8 to 12 hours every day with 0 nitrates in your system to let those enzymes regenerate. Usually patients take it off at night when they sleep since demand is low.
That is such a critical, practical detail. Class 3. Calcium channel blockers or CCBs.
Calcium is the key that starts the engine. In any muscle cell, it's the ion that triggers contraction. If you block calcium entry, the muscle relaxes. Simple enough?
This applies to the heart muscle, but also, and this is key, to the smooth muscle in the artery walls.
The text splits these into 2 families, dihydropyridines and non-dihydropyridines. I feel like we need to decode that.
It's easier than it sounds. The dihydropyridines are the drugs ending in sampine, nifedipine, amlodipine. Think of these as the pipe openers. They're potent vasodilators. They mostly just relax the arteries.
So they increase supply.
Primarily, yes. And by lowering blood pressure, they also reduce demand a bit.
And the others, verapamil and diltiazem.
These are the non-dihydropyridines. They do dilate vessels, but their superpower is that they act a lot like beta blockers. They slow the heart rate and the electrical conduction through the AV node.
So bringing it back to Prinzmetal spasm angina, since we can't use beta blockers, are these the answer?
Yes, calcium channel blockers are the drug of choice for spasms. They directly relax that twitchy, smooth muscle in the artery wall and stop the clamp down.
But we have to be careful combining them, right? Extremely. If you combine verapamil, which slows the heart, with a beta blocker, which also slows the heart,
You might stop the heart entirely.
or cause a complete heart block where the signal from the top of the heart can't get to the bottom, it's a dangerous combination in the wrong patient.
Finally, class 4, the specialist. Ranolazine. This is the newest kid on the block.
Ranolazine is fascinating because it breaks the rules. It reduces angina, but it doesn't lower the heart rate and it doesn't lower blood pressure.
Which is unique because everything else we've discussed changes the hemodynamics, the numbers. How does it work?
It targets something called the late sodium current.
Okay, let's visualize this. Why does sodium matter? I thought calcium was the key.
Think of sodium as the doorman for calcium. In an ischemic heart cell, a cell that is starving, the sodium channels get leaky. They stay open a little too long.
So too much sodium gets in.
Exactly. And because of the way cells balance their ions, that high intracellular sodium forces an exchanger to work in reverse, pulling excessive calcium into the cell.
And calcium means contraction.
Right. It means the cell stays tense. It can't relax properly during diastole. It's in a state of calcium overload. This increases the stiffness of the heart wall and burns unnecessary energy.
So ranolazine fixes the leaky doorman.
It blocks that late sodium current. It stops the sodium overload, which in turn stops the calcium overload. The cell can finally relax. Tension drops. Energy is saved.
That is elegant. So this is the perfect add-on drug. If you have a patient who is already on a beta blocker and their heart rate is 50, you can't give them more.
Exactly. You've hit the floor on heart rate, but they still have pain. Ranolazine is the answer because it won't drop the heart rate any lower. It just makes the engine run more efficiently at the cellular level.
Is there a downside? There's always a catch.
Always. It prolongs the QT interval on the ECG. This is the time it takes for the heart to electrically reset after a beat. If that gets too long, it can spiral into a chaotic, life-threatening rhythm called torsades de pointe. So you have to monitor the ECG.
Okay, we've got the tools. The governor, beta blockers, the unloader, nitrates, the pipe openers, CCBs, and the efficiency expert, ranolazine. Section 6 brings it all home with the treatment algorithm. How do doctors actually build a strategy?
It starts with the ABCD of prevention. Before you treat the pain, you have to stabilize the vessel and prevent the ultimate catastrophe.
A is for aspirin.
Keeps the blood thin so platelets don't stick to the plaque and form a clot, usually a low dose for life.
B is for beta blockers and blood pressure.
Especially if they've had a prior MI, it protects the muscle and get that blood pressure under control.
C is cholesterol and cigarettes.
Statins to shrink the plaque and stopping the smoke to save the lining of the arteries.
And D is diet and diabetes.
Sugar control is vascular control. They're intimately linked.
Once that foundation is set, we treat the symptoms step by step.
Step 1 is always sublingual nitro. Everyone with known IHD carries a bottle in their pocket for emergencies. Start a beta blocker for maintenance. Try to slow the engine down and prevent the attacks from happening in the first place.
If they still hurt.
Step 3. Add a calcium channel blocker or a long-acting nitrate. Widen the pipes or unload the heart.
And if they still hurt. Even with all that.
Step 4. Add ranolazine. The latter. You climb it until the symptoms resolve.
The text ends with a really important note on how we define resolution. It's not enough for the patient to just say, I feel better.
No, because of the silent ischemia issue we discussed, feelings are not facts in IHD. You need objective data.
So you test them again?
You put them back on the treadmill. Can they walk longer now before the ECG changes? Has their blood pressure dropped? Is the resting heart rate actually at that target of 50 to 60?
You're checking the gauges, not just asking the driver how the car feels.
Exactly. We need to know the ischemia is gone, not just the pain.
This deep dive has really changed my perspective. IHD isn't just bad luck. It's a mechanical failure of a complex system. But it's a system we understand and one we can tune.
It is. It's physiology and physics. And when you understand the variables, the heart rate, the preload, the contractility, you can manipulate them to save the engine.
I want to leave our listeners with a thought that really stuck with me from this reading. We talked about pain as the alarm system. In our culture, we're often taught to ignore pain, to tough it out.
The no pain, no gain mentality.
Exactly. But in the context of the heart, pain is information. It is a gift. It is the only warning you might get that the supply chain is breaking down.
That's a profound way to look at it. If you have a high pain threshold, or if you ignore those subtle signs of pressure or breathlessness because you don't want to be a bother, you are silencing the only alarm you have.
So respect the double product, respect the mechanics of your own engine, and don't be afraid to check the gauges.
And keep the flow moving.
Thanks for diving in with us. We'll see you on the next one.